Ventilator loops plot the relationship between two variables within a single breath rather than over time. The most commonly used loops are the pressure-volume loop and the flow-volume loop. In these displays, each point on the curve represents simultaneous measurements of the paired variables at that moment in the breath. Because time is not on either axis, the loop shape reflects how the lung behaves mechanically as it inflates and deflates. During the inspiratory phase, the loop traces the path of increasing pressure and increasing volume, or increasing volume and increasing flow, depending on which loop is being viewed. The expiratory phase traces the return path as elastic recoil pushes gas out of the lung. The inspiratory and expiratory limbs together form a closed figure when the breath begins and ends at the same baseline. The purpose of loops is to provide a compact view of overall mechanical behavior. The slope and curvature of the inspiratory limb reflect how easily the lung accepts volume as pressure rises. The shape of the expiratory limb reflects how smoothly the lung empties. Because the entire breath cycle is shown in one image, loops make it easier to appreciate compliance, resistance, alveolar recruitment, and the presence of leak. Basic directional patterns also carry meaning. A counterclockwise loop indicates the normal progression of inflation followed by deflation. A clockwise pattern often signals a leak or artifact because the inspiratory and expiratory points do not retrace the same path. By comparing the two limbs, loops reveal mismatches between inflation and deflation that might not be obvious on time-based scalars. Loosely interpreting loops complements the analysis of scalars by showing how changes in pressure or flow translate into changes in volume across the entire breath. The pressure-volume loop plots pressure on the horizontal axis and volume on the vertical axis, showing how the lung expands and recoils throughout a single breath. As pressure increases during inspiration, the loop rises along the inspiratory limb as the lung accepts volume. When inspiration ends and exhalation begins, the loop returns along a separate path down the expiratory limb as elastic recoil releases the stored volume. The shape and slope of the loop provide direct information about the lung's elastic properties. A steeper slope indicates that small increases in pressure generate larger increases in volume, reflecting better compliance. A flatter slope indicates that even substantial pressure increases only generate small changes in volume, signaling reduced compliance. The loop normally traces a counterclockwise direction. This reflects the physiologic sequence of pressure rising before volume returns, with the expiratory limb following a different path than the inspiratory limb due to hysteresis in the lung chest wall system. Hysteresis is the difference between inflation and deflation behavior caused by alveolar recruitment, surface tension, and the mechanics of opening and closing lung units. Because the loop displays the inflation and deflation phases together, it provides a concise picture of how the respiratory system responds to ventilator pressure across the entire breath. The loop's contour, slope, and overall size reveal compliance, the degree of recruitment, and the efficiency of elastic recoil. A normal pressure-volume loop begins at the level of positive and expiratory pressure. As inspiration starts, pressure rises gradually, and the lung accepts increasing volume. The inspiratory limb forms a smooth, upward curve. The steepness of this slope shows how compliant the lung is. When compliance is good, a small rise in pressure produces a noticeable increase in volume, creating a steeper path. When compliance is lower, the limb rises more slowly because more pressure is required to add the same amount of volume. At end inspiration, the loop transitions into the expiratory limb as the lung recoils. Volume decreases as elastic forces drive gas out of the airways. This return path does not exactly overlap the inspiratory limb. Instead, it lies slightly to the right, forming a characteristic hysteresis loop. The separation between the two limbs reflects the normal physiologic differences between lung inflation and deflation, which arise from surfactant behavior, alveolar recruitment and derecruitment, and the relative ease of emptying compared with filling. The overall contour of the loop has a sigmoid shape, with a gentle rise early in inspiration, a more linear portion through the mid-range, and slight flattening near the top as the lung approaches its natural limits of expansion. The area enclosed by the loop corresponds to the elastic work of breathing needed to inflate and deflate the lung. This pattern represents efficient, stable lung mechanics, a smooth counterclockwise loop with a consistent starting and ending point. a well-defined hysteresis gap, and a slope that matches the expected compliance of the neonatal lung. Inflection points are specific regions on the inspiratory limb of the pressure-volume loop, where the slope changes noticeably. These changes mark transitions in how the lung responds to pressure as it inflates. At low pressures, the curve often begins with a relatively flat segment because many alveoli remain collapsed. Small increases in pressure produce minimal increases in volume during this early portion of the loop. When pressure reaches the lower inflection point, the curve turns upward more sharply. This indicates that a threshold has been crossed, where alveoli begin to open and recruitment accelerates, allowing volume to rise more efficiently for each additional unit of pressure. As pressure continues to rise through the mid-range, the slope becomes more linear. In this zone, alveoli recruit progressively, compliance is highest, and the lung expands in a stable and efficient manner. This region between the lower and upper inflection points represents the optimal operating range for ventilation, where pressure is neither too low to keep alveoli open nor high enough to begin overstretching them. Near the top of the curve, the slope begins to flatten again. This change marks the upper inflection point. Beyond this point, additional pressure produces progressively smaller increases in volume because the lung is nearing the limits of safe distension. Alveoli become overstretched and compliance decreases, so the curve bends toward a plateau. This transition signals the onset of overdistension. Identifying these inflection points allows recognition of the pressures at which alveoli begin to open and the pressures at which they begin to overstretch. The segment between these 2 points defines the most stable and protective range for ventilation. Below the lower inflection point, the majority of alveoli remain collapsed. In this low-pressure region, the lung is operating at very small volumes, and surface tension forces dominate. Because many alveolar units are still closed, increases in pressure result in only minimal increases in volume. This portion of the loop reflects derecruitment and atelectasis, where ventilation is inefficient and unevenly distributed. Between the lower inflection point and the upper inflection point, alveoli progressively open as pressure rises. Recruitment becomes more uniform, and compliance is highest in this pressure range. Here, small increases in pressure generate relatively large increases in volume because alveoli are transitioning from closed to open states. This middle zone represents the most efficient and stable range for ventilation. Alveoli remain open, tidal ventilation is more evenly shared, and elastic work is minimized. Above the upper inflection point, the lung approaches its mechanical limits. Pressures beyond this region no longer produce meaningful recruitment, and compliance decreases. The curve flattens because alveoli are being stretched rather than recruited. This marks the onset of overdistension. In this region, additional pressure produces only small increases in volume, while mechanical stress on the alveolar walls rises, increasing the risk of volutrauma and barotrauma. These regions of the pressure-volume loop illustrate 3 distinct lung behaviors: collapse and derecruitment below the lower inflection point, optimal recruitment and compliance between the lower and upper inflection points, and overdistension above the upper inflection point. A flattened inspiratory slope on the pressure-volume loop indicates that the lung is accepting very little volume for each increment of pressure. This pattern reflects decreased compliance. Instead of rising steeply as the lung fills, the inspiratory limb becomes shallow and elongated because the lung is stiff. More pressure is required to generate the same change in volume, so the loop shifts to the right. The entire inflation curve moves toward higher pressures because the system resists expansion throughout the breath. This rightward displacement is a fundamental sign of reduced distensibility. Conditions such as surfactant deficiency, pulmonary edema, fibrosis, or evolving lung injury increase the elastic load. When elastic recoil is strong and the lung is difficult to expand, the volume gained at each step of pressure diminishes. The pressure-volume loop reflects this by stretching horizontally, showing that higher pressures are being used to achieve volumes that normally would occur at lower pressures. On the expiratory limb, the deflation curve may also appear smaller or narrower because the stiff lung stores less volume at a given pressure. The distance between the inspiratory and expiratory limbs may remain present, but the overall loop is compacted and shifted toward the right side of the graph. This combination of a flattened inspiratory path and a rightward shift shows that the entire system is operating at higher pressures with reduced volume change, representing global loss of compliance. A leftward shift of the pressure-volume loop accompanied by a steep inspiratory slope indicates that the lung is accepting a large amount of volume for a relatively small increase in pressure. This pattern reflects increased compliance. Because the lung expands easily, the inspiratory limb rises sharply and reaches higher volumes at lower pressures. The entire loop shifts toward the left side of the graph, where lower pressures are located. This behavior often appears when the lung has been successfully recruited or when compliance has improved due to clinical changes, such as effective surfactant therapy, reduction in inflammation, or resolution of atelectasis. As more alveoli participate in ventilation, the lung requires less pressure to reach a given volume. The loop widens vertically and moves left because the mechanical load opposing inflation has decreased. The expiratory limb often shows a larger volume range as well, because the recruited lung stores more gas at end inflation. The deflation curve may remain smooth and broad, reflecting adequate elastic recoil despite the lower pressures used during inflation. The key mechanical message from this pattern is that the respiratory system is operating in a more distensible state. The steep slope signifies efficient volume gain for each increment in pressure, and the left shift shows that the lung achieves this expansion with reduced applied pressure. Beaking refers to the flattening or outward bulging of the top portion of the pressure-volume loop during inspiration. Instead of continuing to rise smoothly as pressure increases, the loop bends outward and forms a horizontal or convex shape. This pattern indicates that the lung has reached the limits of safe distension. Additional pressure is no longer producing a meaningful increase in volume. Instead, it is overstretching already open alveoli. Mechanically, this occurs when the lung has moved beyond its upper operating range. As pressure rises past the point of optimal inflation, the alveolar walls become taut. Compliance decreases sharply, so even large increases in pressure generate only small changes in volume. On the loop, this reduced volume gain manifests as a flattened or beaked contour at the top of the inspiratory limb. This appearance is a key marker of overdistension. It signals that the applied peak inspiratory pressure or the delivered tidal volume is too high for the current lung condition. Because the ventilator continues to push pressure into a system that can no longer accommodate additional volume, the alveoli experience high mechanical stress. The slide correctly notes that this pattern raises concern for potential barotrauma. Correction involves reducing the pressure or tidal volume to bring the breath back into the region where the lung fills efficiently without being overstretched. Lowering the target pressure or reducing tidal volume shifts the loop downward and reduces the beaking, placing ventilation back within the range that maintains recruitment without excessive distension. A wide pressure volume loop indicates increased hysteresis between the inspiratory and expiratory limbs. In a normal loop, the two limbs separate slightly because of the natural differences between inflation and deflation. When the loop becomes markedly wider, the distance between the inspiratory and expiratory paths has increased, signaling a change in the mechanical behavior of the lung. The most common cause is increased airway resistance. When resistance is elevated, whether from secretions, a partially obstructed or kinked endotracheal tube, or the chronic airway changes seen in bronchopulmonary dysplasia, the lung inflates and deflates less efficiently. During inspiration, pressure must rise further to overcome the added resistance before volume increases. During expiration, flow is slowed and the lung empties more slowly. These delays in inflation and deflation create a larger horizontal separation between the two limbs of the loop. This widened loop represents the additional work required to move gas in and out of a resistive system. The inspiratory limb shifts rightward at lower volumes because pressure is being spent overcoming resistance rather than expanding the lung. The expiratory limb becomes displaced because the narrowed airways prolong emptying and change the pattern of recoil. The slide notes appropriate corrective actions: removing secretions, straightening a kinked tube, or providing bronchodilator therapy in infants with reactive airways reduces resistance and narrows the loop. When resistance falls, the inspiratory and expiratory limbs move closer together, and the hysteresis pattern returns toward normal. Incomplete closure of the pressure-volume loop occurs when the expiratory limb does not return to the same starting point as the inspiratory limb. Instead of forming a closed, continuous loop, the cycle ends at a higher volume or fails to converge back to the baseline. This indicates that the lung is not returning to its true resting volume before the next breath begins. One common cause is a leak around an uncuffed endotracheal tube. During expiration, part of the exhaled gas escapes around the tube, rather than passing through the circuit where volume is measured. Because the ventilator only records volume that returns through the sensor, the expiratory limb stops early. The loop remains open because not all of the delivered volume is accounted for during the return path. Autopositive end expiratory pressure can produce the same appearance. When the lung does not have adequate time to empty, either due to a short expiratory interval or increased airway resistance, the lung begins the next breath with excess residual volume. The expiratory limb ends above baseline because the lung has not fully deflated back to its starting point. This elevates end expiratory volume and prevents the loop from closing. Both leak and air trapping share the same visual sign. The inspiratory limb rises normally, but the expiratory limb terminates early and does not meet the baseline. The distinction requires correlation with flow time scalars. A leak produces reduced expiratory flow and smaller measured volumes. Air trapping produces persistent expiratory flow that fails to return to zero. Correction focuses on addressing the cause of the incomplete return. For leaks, stabilizing or repositioning the tube reduces bypass flow and restores accurate measurement. For air trapping, extending the expiratory time allows the lung to return closer to baseline. Once the underlying issue is resolved, the expiratory limb meets the inspiratory starting point again, forming a complete loop. A fishtail pattern on the pressure-volume loop appears at the very beginning of inspiration, where the curve briefly dips inward before rising. Instead of starting with a clean upward deflection as pressure increases, the loop shows a small notch or inward bend. This represents the patient generating negative inspiratory effort before the ventilator begins delivering flow. Mechanically, this inward movement reflects the patient pulling volume into the lung with their own muscular effort. As the patient initiates a breath, intrathoracic pressure drops. The pressure-volume loop records this as a shift leftward or downward before the ventilator's pressure rise begins. Once the ventilator senses the effort and triggers the breath, the loop moves into the typical inspiratory path. The size of the fishtail corresponds to the amount of work the patient is doing to initiate inspiration. A small fishtail indicates minimal effort, while a larger one shows that the patient must generate more negative pressure to trigger the breath. This increased work of breathing may occur when trigger sensitivity is too low, when there is significant autopositive end expiratory pressure that must be overcome, or when the patient's inspiratory muscles are working against resistance. The fishtail pattern therefore indicates that the patient is contributing effort at the beginning of inspiration rather than the ventilator initiating the breath alone. The presence of this pattern suggests increased work of breathing at the onset of inspiration and may point to a need to adjust trigger sensitivity or reduce the mechanical load the patient must overcome. In neonates, the pressure volume and flow volume loops are strongly shaped by the very small tidal volumes used in ventilation. When tidal volumes are only 3 to 6 milliliters per kilogram, even a modest leak around an uncuffed tube removes a significant portion of the delivered or returned gas. Because the loop displays only the measured volume, any loss appears as incomplete loop closure or a distorted expiratory limb. Small volumes magnify this effect, making leaks much more visually prominent than in older children or adults. Sensor location also plays a major role. When sensors are placed proximally near the airway, they capture the true volume entering and leaving the infant. This reduces distortion caused by circuit compliance, where part of the delivered volume is temporarily stored in the tubing rather than reaching the patient. Proximal sensors therefore generate more accurate and stable loop shapes, especially when volumes are very small. The loop shapes also change in predictable ways with common neonatal disease patterns. In respiratory distress syndrome, compliance is low, and the pressure-volume loop shifts to the right with a flatter slope because higher pressure is required to deliver each increment of volume. After surfactant, compliance improves quickly, and the loop shifts left with a steeper slope. In bronchopulmonary dysplasia, the loop often widens and becomes irregular because different lung regions have very different time constants. Some units inflate and empty quickly, while others inflate slowly, producing uneven hysteresis and distorted contours. Clinically, identifying these patterns helps guide ventilator adjustments. Setting positive end expiratory pressure just above the lower inflection point helps maintain alveolar recruitment without dropping back into collapse. Avoiding pressures beyond the upper inflection point prevents overdistension, where the loop flattens at the top and alveoli stretch excessively. Because neonatal lung conditions change rapidly, after surfactant, during diuresis, or as BPD evolves, monitoring how loop shape shifts over time helps evaluate the infant's response to therapy and ensures the ventilator continues to operate within the lung's safest mechanical range. The flow-volume loop plots airflow on the vertical axis and volume on the horizontal axis, creating a closed loop that represents a complete breath. Every point on the curve shows the flow that occurs at a specific lung volume, which allows the inspiratory and expiratory phases to be compared directly within a single image. During inspiration, the loop rises above the zero flow line as air moves into the lungs. The inspiratory limb shows how flow behaves at different lung volumes, including the peak inspiratory flow. When mechanics are normal, this limb is smooth and gently curved. During expiration, flow becomes negative as air leaves the lungs, and the loop traces the expiratory limb. This part of the curve shows the peak expiratory flow and the pattern of flow decline as passive recoil drives exhalation. Because the loop links flow and volume rather than flow and time, it becomes a powerful tool for recognizing changes in airway resistance, obstruction, or flow limitation. A narrowed airway alters the steepness and shape of the expiratory limb, while upper airway or endotracheal tube obstruction shifts the entire loop and lowers both peak inspiratory and peak expiratory flows. Flow limitation, such as that seen in airway collapse, produces a plateau or flattening of the expiratory limb. The loop is also highly effective for detecting leaks, air trapping, or asynchrony. A leak reduces the measured expiratory volume and prevents the expiratory limb from returning to the starting point. Air trapping shifts the loop rightward or causes it to end at a higher volume than where it began. Asynchrony can produce irregular shapes that interrupt the expected contour. In neonatal ventilation, these features are more sensitive because the tidal volumes are extremely small and uncuffed tubes allow gas to escape around the airway. Even minor leaks cause the inspiratory and expiratory limbs to fail to meet, and the overall loop shape becomes distorted. Proximal flow sensors make the loop more accurate by minimizing circuit-related errors. In pulmonary function testing, the flow volume loop is displayed with exhalation on the upper portion of the graph. The patient begins at total lung capacity and exhales forcefully, producing a rapid rise to peak expiratory flow. As lung volume decreases, flow gradually falls, creating the descending limb characteristic of forced expiratory maneuvers. After reaching residual volume, the patient inhales, and the inspiratory limb appears on the lower half of the graph. This orientation reflects the natural direction of airflow during spontaneous breathing, where expiration is a positive flow event and inspiration is negative flow. On the ventilator, the convention is reversed because the machine is actively pushing flow into the lungs. During mechanical inspiration, the ventilator generates a positive flow signal, so the inspiratory limb appears on the upper half of the loop. When the ventilator transitions to expiration, flow becomes negative as gas leaves the lungs passively, placing the expiratory limb on the lower half of the graph. The loop therefore appears flipped compared with a pulmonary function test. Although the orientation differs, the physiologic meaning is the same. The inspiratory limb shows how flow behaves at progressively larger lung volumes during inflation, and the expiratory limb shows the pattern of passive recoil as the lung empties. Recognizing the difference in orientation helps interpret loops accurately when comparing diagnostic testing images with ventilator graphics at the bedside. A normal flow volume loop begins at zero volume and moves upward as gas flows into the lungs. The inspiratory limb rises smoothly to the peak inspiratory flow. The exact shape of this limb depends on the ventilator's inspiratory flow pattern and how much spontaneous effort the patient contributes. When mechanics are normal, the inspiratory limb has a rounded, continuous contour without interruptions. As expiration begins, the loop crosses below the zero flow line. The expiratory limb reflects passive emptying of the lung, driven entirely by elastic recoil. It extends downward and then gradually returns toward the baseline as lung volume approaches the end expiratory level. Peak expiratory flow typically mirrors peak inspiratory flow in both magnitude and timing, demonstrating a balanced system with efficient filling and emptying. A normal loop is a smooth, closed figure. The inspiratory and expiratory limbs connect at both ends, forming a complete cycle that represents the full tidal breath. There should be no notches or flattening at the top of the loop. Any beaking or sharp deviation at the peak would suggest overdistension or flow mismatch. In a normal loop, the contour remains clean and continuous. The area enclosed by the loop corresponds to the delivered tidal volume. When the ventilator is delivering consistent breaths and the lung is responding predictably, this area remains uniform from breath to breath. Symmetry between the inspiratory and expiratory limbs indicates that gas moves into and out of the lungs efficiently and that resistance, compliance, and timing are balanced. The slope and contour of the flow volume loop reflect how compliance and resistance shape each phase of the breath. When the inspiratory limb is steep, the lung is accepting flow easily, indicating good compliance. When the limb appears flattened or narrowed, greater pressure is required to generate flow, which reflects either decreased compliance or increased resistance. The expiratory limb is especially sensitive to airway resistance. A concave or scooped appearance during expiration develops when there is narrowing from secretions, bronchospasm, or tube obstruction. If the airway narrows abruptly, such as from a small endotracheal tube or retained secretions, the expiratory limb becomes steep and narrow because flow is limited at all lung volumes. Flow limitation occurs when the expiratory flow plateaus, even while lung volume continues to fall. This reflects dynamic airway collapse. The airways narrow during exhalation and prevent flow from increasing despite the ongoing recoil of the lung. This produces a flattened upper portion of the expiratory limb. The loop also helps detect leaks. When a leak is present, the inspiratory and expiratory limbs fail to meet at the baseline. The loop does not close because some of the exhaled gas bypasses the flow sensor. Instead of returning to the starting point, the expiratory limb ends early or at a lower measured volume. Interpreting these features in context requires correlating the flow volume loop with the pressure volume loop. Resistance-related changes, such as obstruction or flow limitation, distort the expiratory limb of both loops, whereas compliance changes primarily alter the slope of the pressure volume loop. Reviewing both patterns together helps determine whether the abnormality arises from stiffness, airway narrowing, or a leak. A scooped expiratory limb occurs when the expiratory flow falls prematurely and creates a concave, sagging shape, rather than a smooth, rapid descent. Instead of reaching a sharp peak and tapering predictably, the expiratory limb dips inward. This pattern indicates expiratory flow limitation or obstruction. The underlying mechanism is narrowed or collapsible airways. During passive exhalation, the lung recoils and drives flow outward. If the airways are narrowed by secretions, inflammation, bronchospasm, or structural changes, such as those seen in bronchopulmonary dysplasia, the pressure inside the airway falls below the surrounding pressure. This collapses or restricts the airway, preventing flow from increasing even if the lung still has elastic recoil available. The curve therefore scoops inward because the airways cannot sustain flow at mid to low lung volumes. The reduced peak expiratory flow on the loop further reflects the effect of obstruction. When resistance is high, the ventilator cannot achieve the expected expiratory flow, and both the maximum flow and the overall contour are blunted. The loop shows this as a lower and more concave expiratory limb. The slide notes appropriate corrective actions. Clearing secretions with suction removes mechanical blockage. Bronchodilator therapy can reduce airway smooth muscle constriction in reactive airways or bronchospasm. In chronic lung disease, addressing underlying heterogeneity in time constants may also improve the shape, but immediate correction focuses on reducing resistance so that passive exhalation can proceed more normally. Incomplete loop closure occurs when the inspiratory and expiratory limbs of the flow volume loop fail to meet at the same starting and ending point, On a normal loop, the expiratory limb returns precisely to the inspiratory baseline, forming a closed figure. When a leak is present, the loop remains open because the volume returning through the flow sensor is less than the volume that was delivered. The most common cause is leakage around an uncuffed endotracheal tube. As the infant exhales, part of the gas escapes around the tube rather than flowing back through the ventilator circuit. Since the ventilator only measures the gas passing through the sensor, the expiratory limb ends prematurely and does not return to the true baseline. The inspiratory limb remains normal because the ventilator measures delivered volume accurately. The error arises only during exhalation. A poor tube fit, malposition, or partial circuit disconnection produces the same appearance. Any defect that allows exhaled gas to bypass the sensor creates a measurable gap between the limbs of the loop. The size of the opening often corresponds to the amount of leak present and may fluctuate with patient position or airway pressure. Mechanically, the open loop reflects a simple mismatch. Delivered volume is higher than measured returned volume. Because the loop's endpoint no longer corresponds to functional residual capacity, interpretation of tidal volume and flow patterns becomes unreliable until the leak is corrected. Correction focuses on ensuring a sealed and continuous circuit, confirming endotracheal tube depth and position, securing the tube to minimize movement, and checking all circuit connections restore accurate flow measurement. As soon as the leak is resolved, the expiratory limb returns to its baseline and the loop closes normally. Incomplete return on the flow volume loop occurs when the expiratory limb does not come back to its starting point at the end of exhalation. Instead of returning to the same baseline volume that began inspiration, the loop ends higher on the volume axis. This indicates that the lung has not fully emptied before the next breath begins. The underlying mechanism is air trapping. During normal expiration, flow becomes negative and decreases smoothly to zero as the lung returns to its resting volume. When airway resistance is high, such as from small airway collapse, inflammation, or heterogeneous time constants, the lung cannot empty quickly enough during the available expiratory time. As a result, expiration ends prematurely with residual gas still in the lung. On the loop, this appears as an upward shift of the entire expiratory limb. The normal loop shows a full return to baseline, but the abnormal loop ends above that point because the lung is retaining volume breath after breath. This trapped volume raises functional residual capacity and contributes to intrinsic positive end expiratory pressure. The correction focuses on allowing the lung more time to empty. Extending the exhalation period, either by lowering the respiratory rate or adjusting the inspiratory to expiratory ratio, lets passive recoil bring the lung volume fully back to its baseline. Once the expiratory time matches the child's mechanical time constant, the loop returns to a closed figure and the expiratory limb meets the starting point again. Flattened inspiratory and expiratory limbs with a noticeably reduced loop area indicate that the tidal volume moving through the system is small and that the lung is contributing very little flow for a given change in volume. The loop appears narrow and compressed because both the inspiratory and expiratory flow peaks are diminished and the total volume enclosed by the loop is reduced. This pattern is most characteristic of restrictive physiology. When compliance is low, as seen in respiratory distress syndrome, pulmonary edema, or other stiff lung processes, the lung accepts only a small amount of volume for each increment of pressure. Because the tidal volume is limited, the inspiratory limb cannot rise to the expected peak, and the overall height and width of the loop shrink. Expiratory flow also remains low because the lung is storing less volume and has less elastic recoil available to drive exhalation. A very small tidal volume can produce the same appearance, whether it is set intentionally or reduced due to secretion burden or partial obstruction. Secretions can diminish the effective volume delivered and slow the airflow through the endotracheal tube. When the airway is partially obstructed by mucus, both inspiratory and expiratory flows flatten, further reducing the size of the loop. The resulting loop has two defining features: low flow on both limbs and a noticeably small enclosed area. This reflects the limited ventilation and reduced dynamic movement of gas within the restrictive lung. When the lung is recruitable, such as early in neonatal RDS, increasing positive end expiratory pressure may improve the loop shape by opening collapsed units and restoring volume exchange. When the flattening is due to secretions, suctioning restores patency and expands the loop by allowing normal flow to return. Serrations, or an irregular, jagged contour on the flow volume loop, indicate that flow is fluctuating rapidly and unpredictably during the breath. Instead of forming a smooth inspiratory and expiratory pattern, the loop develops small oscillations, sawtooth edges, or uneven deflections along either limb. One common cause is secretions. As mucus moves within the airway or the endotracheal tube, it intermittently alters resistance. Each small shift changes flow for a brief moment, producing the serrated, choppy pattern on the loop. These distortions often cluster in the region where the secretion physically obstructs or vibrates within the tube, which explains why the irregularity may be more prominent on one portion of the loop than another. Asynchrony or agitation produces a similar visual pattern. When the infant attempts to breathe out of phase with the ventilator, triggering small bursts of inspiratory or expiratory effort, their muscular contractions alter airway pressure abruptly. These momentary pressure changes appear as spikes or dips in flow, giving the loop a fragmented or irregular contour. Trigger or flow mismatch can also contribute. If the ventilator does not sense the infant's effort reliably, or if the set flow does not match the infant's demand, the breath becomes unstable. Small failed trigger attempts or aborted efforts create brief interruptions in the flow profile, again adding serrations to the loop. Correction depends on the underlying source. Suctioning clears secretions and restores a smooth flow path. Adjusting trigger sensitivity improves synchrony by allowing the ventilator to detect and respond to smaller inspiratory efforts. If agitation or discomfort is driving the irregular contour, addressing the infant's comfort reduces the erratic pressure fluctuations. Once the source of the instability is resolved, the loop returns to its expected smooth, continuous shape. Tubing compression appears on the flow volume loop as an abrupt, unexpected change in expiratory flow that does not match the lung's normal emptying pattern. Instead of a smooth downward curve, the expiratory limb shows a sudden vertical drop or a sharp kink. This reflects recoil from the ventilator's corrugated tubing rather than a true change in the infant's airway mechanics. During inspiration, some of the delivered gas compresses the flexible ventilator tubing. When the ventilator cycles into expiration and airway pressure rapidly falls, the tubing recoils and releases this stored gas all at once. This extra burst of flow briefly adds to the infant's exhaled volume and creates a sudden spike or step change on the expiratory limb of the loop. The green shading in the diagram represents the slow, physiologic emptying of the lung. The red region marks the abrupt, non-physiologic release of compressed gas from the circuit. Because this flow originates from the tubing rather than from the patient's lung, the flow volume loop becomes distorted. The shape does not reflect the infant's true mechanics and may mimic obstruction or sudden airflow changes if not recognized. This artifact is most visible when the tubing has significant compliance, or when larger pressure swings cause greater compression and recoil. Recognizing this pattern prevents misinterpretation. A sharp vertical drop in expiratory flow occurring at the same point in each breath, particularly without corresponding changes in clinical status or pressure volume behavior, indicates circuit-related recoil rather than pathology. Once identified, it is understood as a normal artifact of flexible ventilator tubing rather than a sign of patient deterioration. In neonates, the small internal diameter of the endotracheal tube amplifies resistive losses. Even mild narrowing produces a noticeable reduction in flow, and the flow volume loop becomes distorted as a result. The small tube magnifies any secretions, kinking, or malposition, causing the inspiratory and expiratory limbs to flatten or narrow. Because neonatal airflow passes through a very fine lumen, the expiratory limb frequently appears narrowed even in normal preterm infants. This reflects the naturally small airway size rather than true pathology. Different neonatal lung diseases create characteristic loop patterns. In respiratory distress syndrome, low compliance limits tidal volume and dampens both inspiratory and expiratory flow, producing a small, flattened loop. In bronchopulmonary dysplasia, time constants vary widely across different lung regions. Some areas empty quickly, while others empty slowly, causing widening, irregularity, and distortion of the loop contour. After surfactant administration, compliance improves abruptly. The loop shifts to the left and enlarges because the lung accepts more volume for the same pressure, and both inspiratory and expiratory flow increase. Clinically, trending loop shape helps assess response to therapy. An increasing loop area after surfactant indicates restored compliance and more effective volume delivery. When bronchodilators reduce airway resistance, the expiratory limb becomes less scooped, and peak expiratory flow increases. Leak correction is confirmed when the inspiratory and expiratory limbs reconnect cleanly at baseline, forming a closed figure once again. Because these infants have rapidly changing mechanics, reviewing the loop throughout the course of treatment provides ongoing insight into lung recruitment, resistance, and overall ventilator synchrony.